We are Team CSI, the Clinical SLP Investigators, Evidence Finders. I am Julie Coates.
I'm Elizabeth Farmer. I'm Bridget Warnichak. I'm Megan Fowler.
So before we get started, we wanted to do a little illustration to get you prepared for our presentation. So I need you to find a partner next to you. Just anyone that's next to you. Okay, so out of the pair, I want one person to do what I'm doing, and the other one, I'll tell you what your role is in a second. So one person, put your hands out like this, and then turn them out this way. Now cross under like this, and link your hands. Pull them under and up. Okay, so now the other person in the group, I want you to point to one of your partner's fingers. Do not touch it. Don't touch it. Just point. Okay? And tell them to move that finger when you point to it. Alright, does everyone have a chance to see how that goes? Alright, so if anybody had a little bit of difficulty moving the correct finger, that is normal. We borrowed this little illustration from Mrs. Sharon May, who came to speak in a few of our classes about childhood apraxia of speech, and it's a good illustration for the way of difficulty it is for children with apraxia of speech to communicate, to speak, because they have a motor planning deficit, so they know what they're trying to say, but they have trouble planning the correct movements for their speech. So them trying to speak might feel a little bit like you know the finger you're trying to move, but you're having difficulty moving that correct finger. So as we're going throughout our presentation, we just like you to keep that feeling in mind as we're talking about childhood apraxia of speech and interventions for it.
So our EVP project, it follows a little girl named Rainey. This is a representation of Rainey here in this picture. She's a 4.5-year-old female who was just recently diagnosed with CAS. Her parents started to be concerned when she was about 2. As we know, those milestones that come at 2, it's so important as speech is really rearing its head there, and they just started to think something's not right. So she was just recently diagnosed, and other than those concerns with her parent, her previous history, medical history included, was pretty normal, other than some ear infections that she had. She had PEE tubes, or pressure equalizing tubes, to reverse, to help with the chronic ear infections, and her hearing is back within normal limits. So it was corrected appropriately, and we don't have to worry about that as we continue to talk about Rainey. She currently attends a public preschool, but is getting ready to transition into kindergarten, so some more formal education. And we want to really make sure that this transition goes smoothly for her, and that we're putting the proper supports in place as she continues to provide the environment for most success for her. Her parents, being the loving, wonderful parents that they are, have a lot of concerns for her, and they really want her to succeed. So they're keeping in mind that they want her to engage with her peers and make sure that this social element of being in school and being around these peers, that it really goes as smooth as it can for her. And then as well as her academic success as she's entering this more formal training in kindergarten and the continuing elementary years. We also want to make sure that she builds the proper amount of self-esteem for a little girl, and that she's not affected by maybe her perception of her speech. The one area that we're really going to focus on within our presentation is literacy, because her parents really emphasize the importance of literacy and wanting her to be able to read and gain those emergent literacy skills that she'll be at currently, and then later into her actual reading and reading comprehension, and as everything builds upon one another. And then finally, they want to make sure that her strengths are really capitalized upon as she continues into school, and that those strengths really help guide her through successful school. So for our PICO question, we had, do preschool-age children with childhood apraxia of speech show more developed literacy skills when targeting phonological awareness in combination with speech intelligibility during intervention compared to targeting speech intelligibility alone? So that's a mouthful. So as I break this down for you, we're looking at a population of preschool-age children with childhood apraxia of speech. The intervention that we're looking at is combining a phonological awareness approach with an articulatory approach and targeting those simultaneously in comparison to the traditional articulatory approaches that we see so commonly in CAS intervention. And then our outcome, we're looking to see if by combining these two approaches, if the outcome on her literacy skills will show improvement in these skills. So before we go any further, I do want to give you a kind of a brief definition of the integrated phonological approach that we're going to specifically talk about as our intervention. This is the one we found most common in the research, and it's basically, like I said, combining phonological awareness with speech process and articulatory focus. So simultaneously, you're working towards improving phonological skills as well as improving their speech production. And alongside that, you also get elements of reading and spelling as you're targeting these phonological awareness skills. And so within our articles, it was really nice, one of the group of authors, they provided this link to some of the materials they actually use within their intervention. So I thought I'd show you guys this because I think it could be helpful for future practice. So this is the Integrated Phonological Awareness Program by Gillen, McNeil, and Associates. And these are just a couple examples of the materials that they actually use within their study when testing this intervention in particular. And then so this is an example of one of their phonological awareness activities. So they're working on phoneme segmentation, or wanting the child to count the sounds they hear within the words. So they've provided an explanation and a word list, as you can see there. And then as you go down, you see the cute little pictures that they've placed for the activity as well. So the instructions just basically say, we're going to listen to some words. Each sound you hear in the word, you're going to give the horse a carrot. Gets the kid engaged and helps you kind of test and train that awareness and that perception of the sounds within the words, and that sounds build words. And then as they're targeting the speech sounds, we have these trained and untrained items that they use within their study, and just some ordinary art tip cards pretty much, and just how they implemented those within their study. And that's just an example of some of the materials you can find on their very helpful website. I'm going to turn it over to Julie to explain the articulatory approaches that we're talking about.
So in contrast to the integrated phonological awareness intervention that Megan just presented, a traditional articulatory approach would focus on speech sound production alone. So a common articulatory approach that would be used for children with childhood apraxia of speech would be the Kaufman approach. Most of you who have been in the clinic have seen this or have worked with this directly. So that is a motor learning based approach that focuses on syllable structure, building on syllable structures, and errorless learning with high numbers of repetitions. So these are some examples of the cards that are produced by Nancy Kaufman for the Kaufman approach. And they just have pictures on the front, and then on the back there is a hierarchy of word productions that starts from a more simplified approximation of the word and builds up to the complete target word. So this allows for the errorless learning and allows the child who has trouble sequencing the phonemes to begin with a more simplified version as they're building up to being able to sequence all the phonemes together. So during a therapy session, if I was the clinician and Elizabeth was my child in the session with me, this would be a drill type approach usually where I would present the card and she would say whatever level of the hierarchy we were working on at that time. So it would be a little like this.
Table. E. BB. Muffy.
So that just gives you a little example of what an articulatory approach alone would be. You can see that there weren't words, we weren't focusing on any aspect of phonological awareness in this type of intervention.
So getting into our EVP process, after we reviewed our case study and formulated our PICO question, we started to search for articles. In analyzing the articles, we used a rubric given to us by Dr. Malawista, which really kind of helped us decide which evidence was the strongest and which evidence we wanted to use in making our clinical decision for rating. So on the scale, a maximum was 7 points, so those would represent the strongest articles. And points were awarded to the articles as we analyzed them based on whether they were meta-analyses, randomized control trials, and they received points for other things such as if there was at least one valid and reliable finding, if there were statistically significant results, and if there were notable effect sizes. So, as you can see, based on our table, we found research and used it in our clinical decision that was kind of spread out throughout the levels of evidence. We found one systematic review by Murray, McCabe, and Ballard that reviewed intervention approaches for children with CAS. Following in the hierarchy were a series of studies by McNeil, Gillen, and Dodd that talked about the phonological awareness approach in children with CAS. And then the lower levels of evidence were more of your case studies and expert opinions from those in the field. So, kind of to touch back on CAS and literacy and why we're talking about these two things together, childhood apraxia of speech, as defined by ASHA, is a motor speech disorder that is not associated with any sort of muscular weakness or paralysis. Rather, there is difficulty in motor planning for the coordination of speech movements. So, characteristics of these children include inconsistent speech productions, so they may be able to say a word or an approximation of a word at one point in time, but then when they go back to say it again, it might be something completely different and unintelligible. And these productions are categorized by consonant deletions and distortions and substitutions, as well as vowel distortions. They also have difficulty sequencing syllables and phonemes, and this is particularly so as the productions get longer and more complex. And there's also prosodic issues in CAS, so putting emphasis correctly on syllables as in phrases as you're speaking. And the ASHA website also noted that often a comorbidity in children with CAS is delayed or disordered literacy development. So then moving on to emergent literacy skills. This focuses on the skills that children learn from early development up until throughout the preschool years that really set them up for later success in reading and writing. So these include print exploration, so just knowing that print has a purpose, that it's valuable, as well as pretending to read, pretending to write. And then you move on to phonological awareness, so skills such as just knowing that words are made of sounds, sounds have meaning, and then getting into the deeper phonological skills such as decoding, segmentation, and blending. And then alphabet knowledge, so knowing the letters, knowing the sounds that go along with the letters. And also noted in the emergent literacy information was that children with disordered and delayed speech and language are at risk for development of these important skills. So conveniently, one of the first articles we consulted by Gillen and Moriarty in 2007 was called Childhood Apraxia of Speech, Children at Risk for Reading and Spelling Development. So the article talked about the critical age hypothesis, which basically states that when children's speech and language difficulties are resolved by the time they enter preschool, they're in a better position for literacy success. And of course, the population of children with CAS whose difficulties are not resolved are at risk. Also important to note is that improved intelligibility does not necessarily lead to improved literacy skills. So even if the drill-based therapies are working and helping the child with their intelligibility, there's not a direct relationship to their literacy development. Additionally, these drill-based therapies don't incorporate emergent literacy skills, such as phonological awareness. So if you remember Julie's Kaufman cards, the child is only seeing a picture. They're not seeing the actual word. And in the actual study by Gillen and Moriarty, there were notable differences between the articulation and the spelling of words in the children with CAS. So for example, you see this particular child was about 7 years old. They were able to clearly articulate the word chips, but then when they went to spell it, you can see a T and an N and an SH there. So there's really no relationship between articulation and literacy. So now Julie's going to talk about some of the interventions.
Moving forward from this background evidence that Bridget presented, we thought a good next step would be to look at a review of the treatment approaches a wide variety of treatment approaches that can be used in intervention with children with apraxia of speech. So this article was a systematic review done by Murray, McCabe, and Ballard in 2014, and they surveyed the peer-reviewed literature from 1970 all the way until 2012, and they found 42 different articles that dealt with specifically intervention for childhood apraxia of speech. Within that, they didn't find any randomized controlled trials, and there were 19 just case studies, but they chose to focus on the 23 single case experimental studies that they found, because with the experimental studies, there was quantitative data that came with that. So within their review, they found that in those 23 different studies, there were 13 different treatment approaches that were used in the treatment procedures for the interventions. And those 13 approaches were made up of 6 motor approaches, 5 linguistic approaches, and 2 AAC or alternative augmentative communication approaches. For our purposes of our presentation, we'll focus mostly on the motor and the linguistic approaches. So as they were reviewing the treatment outcomes, they looked at all of those 13 different approaches, and their evaluation of the outcomes of the participants following treatment revealed that there were 3 specific treatments that showed what they classified as preponderant evidence, which meant that the effects of the treatments was replicable among the studies, and the data showed significant improvements across participants, giving promising effects for the future. All of the other approaches were considered to be only suggestive, which meant that it didn't meet one of those criteria for the data outcomes. So of those, there were 2 motor treatments, the integral stimulation DTTC, which is dynamic, temporal, and tactile cueing, which is a strategy that uses a cueing hierarchy to practice the sound production through imitation and multimodal cues. And then the REST treatment, which is rapid syllable transition treatment, which is also a motor learning-based approach, kind of like the Kaufman approach is, but it uses intensive practice with multisyllabic pseudo words to teach the sound productions and the transitions from syllable to syllable. There was also a linguistic-based approach, which, wonderfully, was the integrated phonological awareness intervention that we had looked at previously. And of all the approaches, this approach showed the most participants with statistically significant improvements. Both of the motor approaches showed improvements, a majority of improvements for participants, but not all of them were significant improvements statistically. So the integrated phonological awareness intervention was shown to both reduce the phonological process errors as well as improve the phonological awareness skills of those children. And significantly, that approach had large generalization effects compared to any of the other approaches, which is really significant and great that as we're looking towards literacy skills, those skills that they're learning in the intervention are being able to be generalized into other contexts. So we found that this treatment review was a really good, strong foundation for the integrated phonological awareness approach as we were looking forward into some of the research that had more specific evidence on that exact intervention.
So looking more specifically at the integrated phonological awareness approach, once finding it in the systematic review and finding that it could be the answer for Rainey, overall, I'm going to talk specifically about 3 research articles that we found that were specific to this intervention. And as you can see, McNeil, Gillen, and Dodd, they are the front runners for this approach. And all 3 of the articles I'm going to talk about were by this little cohort. So overall, we found out that integrated phonological awareness is clinically beneficial for young children with CAS. And particularly, our focus was on Rainey. And as these 3 studies did have their differences, coming together, they all specifically targeted speech, so the speech production and the speech intelligibility, going through and looking at these children's speech error patterns and targeting those specifically to each child. So across the board, they didn't just target like, oh, we're going to target fronting for everyone. It was, let's look at the child, let's target one of their processes within the study. And then they simultaneously, as this approach suggests, they looked at phonological awareness, letter knowledge, word decoding, and spelling outcomes. And as you can see, they found major gains in all of those areas. The majority of children within the studies, their target speech sound production did increase, and not only at word level, but at that top level of connected speech, where that's really going to impact their intelligibility. And then again, for the phonological awareness, the majority of children increase these skills, which are, again, important indicators of their future literacy success. Continuing on with these same 3 articles, we found that overall, this approach seemed to have longitudinal benefits as well in these areas that I've mentioned before. So, particularly with preschool and early school age children with CAS. And like this approach suggests, pairing the 2 goals, so the phonological goals with the speech goals, they found that really creates a preventative environment for children as they're entering school age and sets them up really well for those emergent literacy skills so that they'll better perform literacy skills as those develop as they age. We also found, like Julie said, she said there was generalization and there was just expansion of these skills they were learning within therapy. And so we did see that improvements were maintained longitudinally and generalized to other areas as well. Specifically looking at the decoding skills that this approach helps target, they were transferred to connected connected reading performance later on as the children did progress. But one thing to keep in mind, and a lot of our studies pointed out this fact, that even with implementation of this integrated phonological awareness approach, these children still need continued guidance when it comes to written language, and that you're going to have to keep an eye on them and give them the supports they need to succeed within that area. So that was a lot of research evidence. I know that's probably what most of you are thinking, but from all of that, we were able to look at what that exactly means for reining our child in the case study. So, as you can tell by the thumbs up, we determined that the integrated phonological awareness intervention is a beneficial intervention for reining. We looked at the best research evidence, our clinical expertise, and that of our professors and supervisors that we consulted, and the patient's family, their values and preferences. So the research evidence, as we presented, proves the benefits of this treatment for speech, phonological awareness, decoding, and spelling, which are all important skills for literacy. And as far as clinical expertise goes, as the second years learned over the summer, and the first years will soon learn, there's a huge focus right now on literacy and the importance of incorporating speech and language skills for academic success right now in the schools for school SLPs, and also that intervening early is critical for literacy development. So from our clinical opinion, this is a very productive and important intervention from that perspective. And obviously the parental concerns are huge just for such a young child. It's important to make sure that you're addressing the parents' concerns, and this intervention does address the literacy concerns and also the academic success, which together, as those 2 concerns are being addressed, will hopefully make Rainie's self-esteem be built up as she ages and progresses. But we did feel, like Megan said, it's important to note that one future goal that the integrated phonological awareness intervention may not particularly address is the written language skills. So there may be another intervention that needs to be evaluated and looked at for Rainie in the future as she grows and develops.
Alright, so the future directions we'd like to take with this research, if we had more time, would be to directly compare the 2 treatment approaches, because we didn't actually have any articles that did that. We would also like to find a phonological awareness intervention that works with existing CAS methods, such as the Kaufman cards, because that would be clinically relevant. And we would also like to do studies of larger sample sizes, because that would contribute to the certainty of our results. We would additionally like to follow up on literacy skills in later school-age children, because we did have some longitudinal studies, but we didn't have longitudinal studies that followed up that far into the future. And we think that would have major impacts on the clinical relevance of our study. We would like to determine if the effectiveness of the treatment type is impacted by the apraxia severity level finally, because for this study we only looked at Rainey. She has one severity level, but many of the other patients that we would have differing levels, and it would be important to know that. Alright, so this was our EVP process. First, we asked a clinical question. This is where we formed our PICO question. Then we searched for the best available evidence using these databases and these search terms. We analyzed the evidence and we made a clinical decision based on 3 important categories. Based on the patient and her needs and wants, and the needs and wants of her family. Based on the research evidence, and finally, based on the clinical expertise provided to us. Then we made a clinical decision, and in a real case, we would have implemented that decision and evaluated the outcome. And finally, we would like to thank everyone who contributed to the development of our presentation. Thank you to Dr. Bernino for pointing us in the right direction toward valuable resources and for contributing valuable comments throughout the process. Thank you to Mrs. Sharon May for allowing us to use her demonstration and for providing a foundational knowledge of apraxia. And finally, thank you to Dr. Malavista and the MA SLP class of 2016 for your critical feedback, which was very valuable in improving our presentation.
Any questions? Yes.
Thank you very much. I was just wondering if you encountered in any of your articles any distinctions between, say, severity of childhood apraxia speech. Did they ever talk about how severely the children were affected? And then, do you think that that's an important distinction for kids with?
In the systematic review that I discussed, they didn't necessarily classify the interventions based on severity. They did look at the participants in the study as far as the surety that they actually had child apraxia of speech, but it wasn't necessarily a rank of severity. It was just an indicator of how sure they were that the participants had apraxia. So in that article, not necessarily. Megan can speak to the ones that she talked about.
Yeah, the ones that look specifically at this approach, they didn't specifically narrow it down to the severity level, but they did use the OZE model of classification, again, to assure that they had the childhood apraxia of speech. And again, one of them was a case study, so it was a little bit more clear about where those 2 individuals that they followed, they were a mid-level kind of severity. But I do think it's really important to consider in the future. I think they were just saying, here's kids with CAS, let's try the approach, but future directions of breaking it down into different groups of severity would probably be very beneficial.
So I guess the answer to that is no, they really didn't. Not in the articles that we found, and that definitely would be a future direction that would be interesting to see some research, whether a more severe case would be whether severe compared to mild would benefit as much from either one of the intervention types.
Yeah, just thinking in terms of maybe your clinical opinion, if you had somebody who was extremely affected by this, to the extent that they had reproduction whatsoever, would you maybe want to lean toward one approach first before you sort of integrate it on one?
Yeah, based on what we found, it seems like, first off, regardless of severity, the phonological awareness couldn't hurt. So, however, if the child does have very severe intelligibility issues, then of course the motor drill-based therapy would be very beneficial. However, incorporating the phonological approach would add to that.
I think I'd just say, for everybody, that one of the challenges you have in serving these kids is that you don't get to see them enough. And so you have to make really hard decisions about how much time you spend during the sort of precious moments that you have, and then what kinds of things you can offload and have other people follow up with. But this is some of those challenges with research versus the practice, where in a research one, they can do it at a pretty high dose that you'd love to see when you're working in the school system. But in the school, you might be seeing me for 60 or 90 minutes a week, and then you have to make really tough choices. So I think it's where your questions are really important one. Think about how are you going to use that really precious time.
This is somewhat relevant to Dr. McCarthy's question. So one of the future directions that you mentioned is to make a direct comparison between a motor articulatory based approach versus the phonological integrated approach. Say if you actually carried out such a study, and you can have basically just a number of possible outcomes, right? One is they are equally effective. One is one approach is better than the other. And I think this situation is interesting because you're not comparing two independent approaches like A versus B. You're basically comparing A plus B. So given these outcomes, how are these outcomes going to actually influence what you do in your clinical practice? Are you going to say, for example, if they turn out to be equally effective, does that mean you don't do any phonological-based therapy at all?
I think that might depend on the individual child.
Yeah.
I mean, so maybe if they're not having concerns about literacy, then you might not target that.
We kind of talked about when we were determining our future directions, where we were thinking about doing a direct comparison. First of all, we were thinking, well, is it even ethical to do that direct comparison if there's research proving that the integrated phonological awareness approach is effective for intelligibility and literacy, pre-literacy skills, as the research we presented proves. But we kind of thought there isn't research out there, at least that we could find, saying, well, it is actually more effective than articulatory approach alone because there isn't a direct comparison. So maybe you do once they do a couple studies and find out that it is. So I don't know. We were kind of unsure if that comparison was even ethical to make based on the proven effectiveness of the integrated phonological awareness approach. So we kind of were, I don't know, up in the air about that. Does anybody else have anything to add?
Also, in a real-life situation, they would probably have impacted articulation and impacted literacy skills. So you would probably look at using a combination because any patient with apraxia will probably have both issues. Does that answer your question?
Thank you, everyone. If you fill out those forms and just put them at the table on your